All right, good afternoon and welcome to Kauai Health's community webinar. My name is Deborah Volison and I'm the Director of Patient and Community Experience, joined today by Gary Herbst, our Chief Executive Officer. And we want to thank you for joining or listening to these later because it's a great opportunity to find out what is happening at Kauai Health and how it affects our community. And so today we're going to give you an update on FEMA. We're going to talk about our finances, the big, beautiful bill, which is top of mind right now. We're going to share a little bit about our urology services and then some leadership changes at Kauai Health. So, Gary, welcome.
Yeah, thank you, Deborah. Good to be here.
I was actually thinking today, we passed our 5-year anniversary of doing our
first
webinars.
telecast?
Yes. And I don't remember
With
receiving
no real
text.
fanfare or anything, huh?
No, but
Just 5 years. That's
5 years that we have been
Yeah.
doing
You
these.
kind of remember it like yesterday too, though?
Yeah.
I know we were
Yeah.
we were over in the Mertz Mansion at the time, right? And before we built this studio.
And I was running it by myself, and somebody would not mute themselves. Do you remember that? I finally got frustrated and disconnected, and that is when Daniel said, "I'm going to help you." So
We've come a long way.
We've come a long way,
Long way.
but we are always so glad you're able to sit down and just be transparent. I think these last 5 years, if we have been guilty of anything, it's being transparent.
Yeah.
And so thank you for taking the time.
Well, I appreciate it. I actually look forward to this every month, and I still continue to do our biweekly employee huddles as well. So, yeah, this has definitely been one of the silver linings that came out of COVID, is just creating this venue, this opportunity for us to connect with our community, particularly all of you that are active members of our community engagement initiative and belong to either our community advisory committees or our PFAC and EDAC and not ambassador groups. And so, yeah, no, it's great. It's good to be here.
So first question, and we've asked you so many times, I think you just probably want to bang your head into the wall, but when is FEMA going to show us the money?
Yeah, I know I do want to bang my head in the wall, particularly when my answer to your question is the same every time. Although, I don't know, I don't want to jinx it, but feels like it's closer and closer. But as of today, July 24th, we still have not received our $47 million in promised FEMA funds. Very frustrating. We did learn that the checks, because there are two of them that add up to the 47 million, but the checks were actually written, cut by the state back on May 2nd of 2025, which means they had received the funds from FEMA even before then. But they finally wrote the checks, and yes, they are paper checks, just like, well, we don't even write checks anymore to pay bills. I mean, so many of us use bill pay and electronic. You would have thought it would be a wire transfer, but no, the state will actually issue us checks, and they have been written. But as I've shared with you in the past, I think they're purposely hanging on to them. $47 million creates a lot of interest income, particularly if they've had it before May 2nd, which they did, and here we're July 24th. So I'm hanging on to it as long as possible. We did learn that despite, the checks being written in May, that the clock didn't start officially running until we heard from the California Office of Emergency Services back on June 11th that we were notified that it was now in the payment queue within Cal OES. And my recollection, and Melinda Tupper, our CFOs as well, as we were told at that time that it'll probably be 6 to 8 weeks. We now learn that it'll be more like 8 to 10 weeks. And so if we're looking at the far outside, that it's 10 weeks from that June 11th date that we were notified, then we're looking at August 20th. That would be the 10-week mark from that June 11th date. So that would still put us out a full month. Frustrating. We did reach out this week to State Senator Shannon Grove, who's been a huge supporter of Kauai, and we appreciate everything the senator has done for us. I don't know if she's going to be able to bring any influence to it, but I'm cheering her on. Hopefully, she does speak to the governor often. Personally, she has his cell phone number, so perhaps she can pull on the governor's heartstrings to help out a hospital here in the Central Valley that could really use those funds. As I've shared with you, we're using some of those to actually be able to fund 100% of our employee 401k plan for the calendar year 24. We had only budgeted and previously promised and had the ability to fund only 50% of it. But once we learned from FEMA that we were obligated, we actually heard from FEMA back on November 27th. That's when the federal government, through FEMA, actually informed us that our two requests for the $47 million were now formally obligated. So once we and the board learned of that, the board took action to amend the budget to increase the match to the full 100%. So our employees are getting, really, really anxious. The plan year ended back on December 31st. So 7 months ago, and they're still waiting to make that match. So I just continue to ask for their patience. I hope it would not go beyond August 20th. That's what we've been assured, but yeah, still frustrating.
So the second part of that question is, would we ever take legal action to try to get those funds if they don't come within the 10 weeks?
Certainly that's an option always. There have been lawsuits over the years, Kauai Delta Healthcare Inc. versus the state of California. And so when there have been shenanigans being pulled by the state around, Medi-Cal funding or other obligations that they have that they've failed to comply with, we actually have brought suit to them. In class actions where Kauai is the lead entity suing the state. The California Hospital Association has brought lawsuits against the state. I would imagine that when the governor is going against the will of the voters who passed Proposition 35, which meant that at least 50% of that managed care organization tax was going to go to doctors and hospitals. And then the governor said, no, it's not. I'm going to use 100% of it for my general fund and help balance the budget. Although that might, because of the Big Beautiful Act, become all irrelevant. I'm afraid that Proposition 35 and that MCO tax has probably been dashed at this point. But I would imagine that it hadn't been, we'd be bringing a suit against the governor for misappropriation of those Prop 35 funds. So I suspect that no court would take up our lawsuit until we've exhausted all of the administrative remedies, which are generally the case, which means we'd still have to let that 10 weeks, that August 20th date arrive. And if we don't receive the funds at that point and do not have any indication by Cal OES that they intend to release those funds, then certainly that would be an option for us to consider.
Okay, thank you. So let's talk about the financials. So how were the overall financials for fiscal year 2025?
Yeah, so the fiscal year ended on June 30, 2025. And so now we've had enough time pass that we think we have final numbers for the fiscal year. And in fact, last night we had a board meeting and Melinda Tupper, our Chief Financial Officer, presented the final year-end results to the board. Unfortunately, fiscal year 25 turned out to not be as good as we'd hoped. We knew it was going to be a very difficult year. We had implemented more than $32 million in wage increases to our 5,200 employees, driven by just market pressures, but also by Senate Bill 525 that was passed by the legislature and signed by the governor, that established a minimum wage for all healthcare workers in California. So between market pressures and SB 525, that significantly increased our wage costs to our employees. So we had budgeted to actually incur an operating loss for the fiscal year. Approximately 12.4 million was the operating loss, but we actually ended the year with a larger loss. We ended the year with an operating loss of 23.3 million. So again, to remind folks that our operating loss looks at all of our revenue from all sources, the vast majority of it coming from taking care of patients and what we get paid by Medicare and Medi-Cal and Anthem Blue Cross and Blue Shield and so forth. That accounts for about 98% of our total operating revenue. But then we also have revenue that comes in from the lifestyle center and cafeteria sales, things of that nature. Some of our joint ventures that we're involved in, like Sequoia Surgery Center and Quail Park, those are other sources of revenue. So our total revenue for the year actually came in higher than budget. We brought in, a total of $904 million came into the organization in terms of revenue, which was about $23 million more than budget. But our operating expenses, which again, the operating margin is that total revenue minus all of our operating expenses, which more than half is wages and benefits for our employees, but then payments we make to physicians and pharmaceuticals and supplies and energy and food and all those other things that go into operating a hospital. When the dust all settled, we were projecting that those expenses were going to be about $12 million higher than all of that revenue. But again, ended up being higher than we thought. Really, it's all, I would say, almost entirely attributable to higher than budgeted labor costs. Our total labor costs, when you look at both wages and benefits as well as contract labor, we spent $493 million this last fiscal year, which was $39 million more than we had budgeted. So most of that came because we had to use far more contracted nurse travelers than we had thought. We definitely knew that we were going to continue to rely on them. We have a lot of investments going on, creating new nurses through our partnerships with the College of the Sequoias and Fresno City College, Porterville City College, San Joaquin Valley College, now Unitech, Fresno State, lots of wonderful partnerships with them that we invest in and help underwrite the cost of that education for our employees and future nurses. But today we still have 125 traveler, bedside nurses that are helping fill that gap in our employed labor. So we had budgeted that we would spend close to $15 million in nurse travelers. We ended up actually spending almost $26 million, so almost twice the amount that we had budgeted. The vast majority of our travelers we're using in the emergency department and labor and delivery. They're two very intense areas of service that it's hard work, very hard work. They're both incredibly busy. It's very labor intensive and it's very complex, sophisticated care, and not, a lot of nurses are drawn to that. They get there and then it turns out, wow, this is more than I thought. So it traditionally has always been two of the most difficult areas to recruit into, as well as our intensive care units. And you're really looking ideally for experienced nurses. So not as many nurses going straight, out of nursing school into the ED or into labor and delivery. They want to get a little bit more experience under their belt, working as a medical surgical nurse. And so always difficult. But so that was the big reason. But as I mentioned earlier, the board had budgeted to make a 50% match to the 401k plan. But then when we learned about the FEMA funds, they decided to make a full match. So even though the match actually hasn't occurred yet because the FEMA funds haven't been received, we did accrue the liability and recognize the expense. So that added about $5 million in labor costs to last fiscal year that was not budgeted. And then the last thing is we are self-insured for workers' compensation claims. So most companies will purchase a workers' compensation insurance product that they will, pay those premiums to cover when their employees are injured and need medical care or lost wage support. But we've been self-insured my entire 34 years here. So and really we're able to be self-insured because the vast majority of medical care that an injured employee might need can be provided by us, at just really the cost of providing that care. So oftentimes hospitals choose to self-insure because they are also the provider of that workers' compensation medical care. So when you're self-insured, you have to engage a third-party actuary that has to estimate using their actuarial knowledge and algorithms and tables and everything to estimate claim by claim what they think we ultimately have to pay out in terms of disability payments or medical costs. And sometimes those medical costs are ongoing for years if an employee, suffers a certain type of injury. And so every year that actuary kind of based on experience, based on the cost of medical care and disability payments, kind of recasts, reestimates what those reserves should be. And sometimes it goes in our favor where they reduce the reserves, and sometimes it goes not in our favor. And that happened to be the case this year. We got the actuarial valuation, I think, came in May and showed that we needed to increase those reserves by another $5 million. So that becomes an expense to us and not one we were expecting. So when you take the overdependence on contract labor, fully funding the 401k, and that change in workers' comp reserves, that's what caused us to have a loss of about $11-12 million higher than what we budgeted. Now, fortunately, because of those FEMA funds, even though we haven't received them yet, because they have been obligated and acknowledged as a liability, the federal government has already actually funded the $47 million to the state. The state has a recognized, acknowledged liability that they owe us the money and that they intend to pay it. For that reason, we're able to record it as an accounts receivable on our balance sheet at June 30, 2025. So when you take into account that $47 million of FEMA money that is below the line, below that operating margin, or in our case, is operating loss, the bottom line, which we often call net income, we're projecting will actually be a positive $42.1 million. So that's the highest net income that we've had prior to COVID. So over the last 5-6 years. So that's going to be a welcome outcome of this fiscal year, which results in us being in full compliance with our two major financial covenants that are part of our revenue bond indenture. So one of them called the maximum annual debt service coverage ratio, and the other the number of days cash on hand. So as of June 30, 2025, we are in compliance with those covenants. If we can manage to achieve that again next year at the end of June 30, 26, then I think we'll be able to petition the bond trustee to return the $18 million that we had to put into a trust account a couple years ago when we did not meet those covenants.
That would be nice.
Yes.
That would be great. Okay, wonderful. Thank you. You mentioned how busy our labor and delivery department is. We were up there rounding the other day, 23 babies.
We had 21 babies in the NICU last night. It's a 23-bed unit, and 21 neonates in that unit, which many of them were those births you were just describing. I haven't seen it that high in a very long time. So yeah, very, very busy.
Okay, so lots of speculation around the big, beautiful bill. And you've explained it a couple of times, and I know Mark Mertz and the executive team, they've been talking about it at our community advisory councils. So the question that we continue to be asked is, what's our strategy Because several months ago we were predicting, or a few months ago we were predicting what was going to happen. But now that the bill's been approved and you have more of a grasp on the numbers, what is the strategy that CWEA is going to use to offset those costs and to still provide the services that we need in our community?
Yeah, the $64,000 question. Yeah, the One Big Beautiful Bill Act of 2025, more easily referred to as OBBA, OBBBA. So that's what we'll call it from now on. I'm sure there's a lot of words we could substitute for the word beautiful, but we won't go there today. I would say the grasp that you describe is still a very loose grasp. So there is still a tremendous amount of uncertainty around this bill. There are a lot of complexities. The timing of certain things in terms of having been acted on before July 4th, 2025, which is the day that President Trump signed the bill into law. There are things that if you had taken these actions and maybe got this federal approval before that bill was signed, then you might be grandfathered in. So we also, obviously some of the biggest standout elements of that bill was the work requirement now to be eligible for Medi-Cal. Also, now having to go through a redetermination every 6 months instead of annually in terms of maintaining your coverage under Medi-Cal. Also, many Californians receive their insurance through the healthcare exchange, Covered California. And those are folks that perhaps aren't old enough yet to be covered by Medicare, but they don't meet the criteria to be covered by Medi-Cal, which you have to be living at or below 138% of the poverty level. So a lot of folks that get their insurance through Covered California is perhaps their employer doesn't offer it, or what they receive from their employer might be too expensive, and so they choose to go into the healthcare exchange. Well, the premiums for Covered California and all the healthcare exchanges across the country are heavily subsidized by the federal government. So as part of OBBA, the premium support that comes from the federal government is being cut pretty significantly. So now there's great concern that a lot of people will no longer be able to afford the premiums through Covered California, and they'll now become uninsured. So there's so many moving parts right now that we're still trying to figure out. We're putting very rough, gross estimates to how all the different elements of OBBA will impact us. But it's such a serious issue. We want to make certain that anything that we communicate out to our employees, our physicians, our community, that we're very confident in its accuracy. And I don't think we can say that right now. And just to illustrate that, so the California Hospital Association, who spent a lot of time analyzing this bill and how it's going to affect California, and California's roughly 400 hospitals, they're projecting that the impact on revenue for California hospitals, over the 10-year period that OBBA covers, ranges anywhere from $66 billion to $123 billion. So that's an enormous range, which just illustrates the uncertainty. It could be as bad as $123 billion, or not as bad, although it's still very bad to lose $66 billion in funding over the next 10 years. But it's just, again, there's just so much uncertainty to it. So we're working closely with the California Hospital Association, probably more closely with another organization called the District Hospital Leadership Forum. So that is an association that we created over a decade ago that is an association that just represents the 33 district hospitals that operate in California. Kauai being one of them, Sierra View Hospital in Porterville being another. So we have incredible staff that support the DHLF. That many of them came out of the state, the Department of Healthcare Services, so they're very, very fluent in Medi-Cal and all the nuances and everything. And so they are helping us understand how we'll be impacted. The area that will impact us the most, and some of it unique to district hospitals or public hospitals, other pertains to all hospitals, but I don't know how closely you've been following the bill, but you may now be familiar with the term provider tax or state-directed payments. So these programs exist across the country. I think 49 out of 50 states, access additional federal funding to supplement Medicaid through provider taxes and state-directed payments. So in California, the 400 hospitals tax themselves a provider tax to create the Hospital Quality Assurance Fee Program, or HQAF. You may recall years ago that voters passed Proposition 52, which made this provider tax permanent and required that all of the federal funds that it secured would go to hospitals and could not be raked off by the state to cover the budget. Those provider tax programs are part of the cuts that are in OBA. The second one is state-directed payments. So both the designated public hospitals, which are the University of California hospitals, and the county hospitals, which are public hospitals, and district hospitals participate in a state-directed payment program, which is entirely funded by the federal government, but fully approved by the federal government. You go through a very formal process to gain, their review and their ultimate approval before they agree to it and start funding it, which is frustrating that they're characterizing the cuts to those programs as part of their focus on fraud, abuse, and waste, or waste, fraud, and abuse. To me, fraud is something that you're secretly, illegally trying to
very openly doing.
Yeah, but and again, the federal government has approved this in 49 of 50 states. So, but it is being funded entirely by the federal government, and the states are generally, at least in California, our state does not put up any of the funds. The provider tax is put up by providers, and the district hospital directed payment program is put up by district hospitals. We put our money, we make an intergovernmental transfer to the state, who then the state draws down on federal matching funds and then returns the money to us after raking off a little bit for their administrative costs. So those programs are definitely being targeted and will be cut. But they're being phased in over that 10-year period. And so I guess the benefit is the biggest part of the cuts kick in on 1/1/28. So we hospitals have a couple years to figure out how we're going to respond, which now comes to your question, what's our strategy? So I would say it's in flux right now, without a doubt, just like every other hospital. Nobody is insulated or excluded from the impact of OBA. So whether you're a children's hospital like Valley Children's, or a nonprofit tax exempt like St. Agnes or Adventist Health, Community Regional, whether you're a district hospital, a UC hospital, we are all impacted by it. But how much you're impacted by it largely depends on how significant your Medi-Cal population is that you serve. There are hospitals in California, Hoag Hospital in Newport Beach, probably has a very low Medi-Cal population they serve. I remember when I was in public accounting, St. Agnes was a client of mine. They had a Medi-Cal population of about 5% that they serve. the majority of Medi-Cal patients were served by Community Regional Medical Center and UMC, University Medical Center, which was a county-owned and operated hospital. So I don't know if St. Agnes still is at 5%. I would imagine their Medi-Cal patient population has grown since then, but those hospitals, like virtually every hospital in the Central Valley, that have a very high percentage of Medi-Cal patients will be more severely impacted than those that have a much lower percentage. So we were exploring all the options. Our executive team is going to meet next Wednesday and kind of an all-day on-site retreat to explore all the options we have. As you've heard me say in the past, I'd much rather find solutions by growing our revenue, implementing new services, capturing market leakage. Patients that are leaving our community for orthopedic surgery or general surgery or neurosurgery that could be taken care of quite safely and very nicely here. I thought, how do I keep them here? So much rather to grow yourself than to have to cut yourself. But I don't think we can grow ourselves sufficiently to cover the impact that the cuts will have. So if you're paying attention to the news, you've read just this week, USC, UC San Diego, UC San Francisco have all laid off several hundred employees, already preparing for the impact of OBA to have on them. We're going to do everything that we can to prevent that, but there's just so many places that we can look. But we will do nothing to impact the quality and the safety of the care that we provide to our community. So we will work very hard to not have to cut services or curtail services. It may mean that we have to prioritize things, those things that are most critical. Certainly surgical services, neurosurgery, cardiac surgery, a high-performing emergency department, critical care, all those that are essential to maintaining life for our patients and our community will be fully preserved and continue to invest in, again, high quality, high safety, patient satisfying, but perhaps those things that are more on the periphery that are nice to have. And I say nice to have, there's still a patient population that benefits from it and that needs those services, but we may find ourselves with less resources, that there are just certain things that we just won't be able to provide anymore. And sad, but that is the reality. So much more to come. So stay tuned.
Yeah. So speaking of access to services, urology. So Dr. Rosenberg is no longer going to be here at our specialty clinic. And so what happens to urology patients when they're brought into the ED and we need a urologist, or when they just need follow-up care? What's our plan?
Yeah, we are incredibly sad and disappointed to lose Dr. Shiloh Rosenberg. He was an outstanding physician, both in terms of his skill and knowledge, but also just a genuinely nice man, and our patients loved him and we loved working with him. But he actually came to us under the umbrella of the University of Southern California. So he is part of their teaching program, part of their medical staff. He is only able to practice in the United States if he is under the direct supervision of an academic medical center. And so Dr. Rosenberg came to us through our relationship with Dr. Indy Gill, who's the Dean of Urology at the USC Keck School of Medicine. So unfortunately, Dr. Rosenberg was called back home to the mothership, so to speak. So Dr. Gill wanted to bring him back to Southern California and the USC, and he really had no choice but to go, because that's how he's allowed to practice in California and the US until he meets certain criteria where he can be independent and be able to sit for his boards independent of an academic medical center. So very disappointed to see him leave. He was a big part of helping support Dr. Joe Ford, Dr. Marty Pra, Dr. Tui Hong, our three other urologists that practice in their community. I was talking to a patient of Dr. Rosenberg's just yesterday, I think it was, who very frustrated, understandably, that she is not able to continue to go to Dr. Rosenberg. And when I mentioned the other three urologists, she said she'd already reached out to all three of them, and none of them are accepting new patients. So this is obviously highly disruptive to our community and definitely impacts access to care. Urologists are one of those physician unicorn specialties out there. Urologists, gastroenterologists, rheumatologists, so many ologists are just so scarce, particularly in the Central Valley. We have one of the most severe physician shortages than anywhere else in California and sometimes even the country. So what we have decided, and we just formally approved this last week, is that we are going to instruct our physician recruiting team, led by Mark Mertz, our Chief Strategy Officer, to work with kind of like, we talk about traveler nurses. There are also physician staffing companies out there that provide what are called locum tenens physicians. So a Latin term, I don't know the exact translation, but essentially temporary physicians. So we will contract with one or more of these physician staffing companies to place three urologists here at Kuya. So they will apply for privileges to work at Kuya. They'll be part of our medical staff. They'll be here in Visalia. They may not move to Visalia, but they'll do their turns, their rotations. Oftentimes they'll work 7 days on and then off for 7 days, but they'll stay, either in the apartment or a local hotel. But they actually will work in our specialty clinic where Dr. Rosenberg was located. So they will be providing outpatient clinic care as well as covering the emergency department for urology-related emergencies and providing consults, urology consults on patients that are in the hospital, as well as performing both urology inpatient and outpatient surgery. So they'll provide the full scope of services that Dr. Rosenberg has been provided. And we'll have three of them. I think the first one will be here on August 18th. So we're excited. These are high quality physicians that have been vetted. They still will have to meet all of the high standards of our medical staff to be able to practice here at Kuya, as well as our high standards. Ideally, one or more of the locums falls in love with Visalia and Kuya, because they always have the option. We do have to pay a transaction fee to the company, but we've had a number of physicians. Dr. Shelley Bonzel, just an outstanding cardiothoracic surgeon that joined Kuya not too long ago. At one time, she was a locum tenens cardiac surgeon here, and now she's a member of our family and lives in our community. And so hopefully one of these urology locum tenens decides, hey, I want to be part of Kuya and I want to be part of Visalia and its community. But in the meantime, we are aggressively recruiting for urologists to become permanent members of the community. So we're not going to, just rely on hope that one of the locums would want to stay. And even if Dr. Rosenberg didn't leave, we already have been recruiting aggressively for urologists, because we need more than just the three we had and Dr. Rosenberg. We have a physician by the name of Dr. Ackery, who currently lives in Florida, but comes out and does locum work for Adventist Health in Hanford. We've been in negotiation with him. We've had an offer in front of him to come here as a permanent urologist, so we're continuing to have dialogue with him. Excellent surgeon. So we hope he also decides to make Visalia his home.
Right. Thank you. So thank you to Daniel. So the locum tenens is temporary, like you said, but the Latin phrase meaning is to hold the place of. refers to a physician or other healthcare professional who's temporarily filling a position, but to hold the place of.
Gotcha.
Thank you,
All
Daniel.
right. Thank you, Daniel.
Okay, so there's been a lot of new leaders being announced. And so, because we always kind of mention to this group, our staffing updates, different challenges that we're having. So, you want to tell us who the new leaders are and then how many leadership roles are still vacant?
Well, first of all of you that have been in business or have worked for an employer, or you are the employer, you know the importance of having good leaders in your organization. They create the culture. They help you execute your mission and your strategy. And our employees, we hear repeatedly in our employee satisfaction or engagement surveys that their leader is probably the most important source of information and inspiration for them. So having excellent leaders, whether you're in the hospital business or any kind of business, is critically important to the success of a business. So no different than here. So I am delighted to inform all of you that that 3 of our outstanding contracted interim nurse leaders have now joined Cahuilla Health as employees. So Shalene Pete, who hails from Michigan and has been serving as our interim chief nursing officer, has now joined Cahuilla as an employee. So we have erased away that word interim in front of her title, followed by Rhonda Quinones, who hails from Alabama. Rhonda is now our Director of Maternal and Child Health Services. So no longer, actually Rhonda worked here at one time many years ago and then moved away. And luckily, I still remember when I met her on her first day coming back as an interim. And I say, Rhonda, how am I going to convince you to stay? And she laughed and she says, there's not a chance, Gary. I love Alabama. That's where my family is. That's where my husband is. I'm not leaving. Well, she fell in love with Cahuilla again and with Visalia. And so Rhonda's back, and we're thrilled for that. And then most recently, Scott Baker, who hails from Florida. So Scott has been serving as our interim director of emergency medical services, overseeing our emergency department. And Scott, similarly, has fallen in love with Visalia and Cahuilla and is now a permanent member of the Cahuilla Health family. So just thrilled by that. We also are anxiously awaiting the arrival of 2 new directors. So, oh gosh, where was I? So Shannon Vinson. Shannon is now our new director of our medical staff office services. So this position oversees our entire medical staff services. So supports all of our physicians on the medical staff, actually all of our providers, which are physicians, physician assistants, nurse practitioners, certified registered nurse anesthetists, nurse midwives, all providers, all formal members of the medical staff. We have almost 700 of them. So the medical staff office, Odie De Silva and Debbie Robin and others there, they work to support the needs of the medical staff office. They work very closely with Dr. Paul Stefanacci, our chief medical officer and quality officer, who is responsible for the medical staff office services. So Shannon Vinson will be joining us, I think, next month, but we're excited to have him here. And then we have a new director of cardiovascular services. So the director that oversees cardiac surgery, our cardiac cath labs, our cardiac surgery clinic, and just the cardiovascular service line in general as a business service line. So his name is Ahem Zorakat from Jordan. He's Jordanian. And I know I butchered his last name, but Ahem will be here in mid-August. He's coming, I think, from Idaho, where he was in a similar position there, but we're excited to have him join us. And then we have two remaining open positions. So our director of surgical services that oversees, all of the other non-cardiac related surgical services, and then our director of mental health services oversees our acute inpatient mental health hospital as well as our mental health clinics. So we're recruiting for both of those positions at this time. Jag Bath, who's our chief operating officer, just earlier today informed me that we have a director of surgical services candidate coming out next week to do a site visit. So, and Jag is very excited about this individual. So
That is fabulous. And we met one more last night, the director of corporate compliance.
Oh,
out of Louisiana, right?
Yes. Tilly. Oh gosh.
Yeah.
Jill Berry. Okay, not
yes,
Tilly.
Yes.
Jill Berry. Thank you, Dan.
Yeah.
Yeah, you can. Yeah.
Yeah.
So Jill Berry, yes, she is our director of compliance. Just joined us recently. I don't know where she hails from. Louisiana. Yes, I do. So not only is she steeped in compliance experience, but she's also an attorney, a healthcare attorney. So having somebody that, and she's worked in the hospital setting as a chief compliance officer, and but coming here with that healthcare attorney experience is a huge benefit for us. She reports to Ben Cripps, who's our chief compliance and privacy officer. So, which is why Ben has been grinning from ear to ear ever since she accepted the offer that we made to her. So we're excited to have Jill here as well. So definitely have some outstanding leaders that have been joining Kuya and helping elevate our performance and quality and safety and experience for our patients in our community. And we're receiving a lot of very positive feedback. I know we still have a long way to go before we can say world class every person every time, but we're definitely moving in the right direction. I think Deborah last night read a couple recent feedback that we'd received from a couple patients that just had nothing but praise and accolades for the care they received. Outstanding nurses and physicians. So want to keep hearing more of that.
Yeah, it's great. Thank you. All right. Lastly, talking about leadership changes, you sent out an email a couple weeks ago, announcing your goal and your decision to retire.
Yes.
And so out in the community, I've been met with really mixed responses, and I think people are kind of tiptoeing.
Someone's saying good riddance,
No,
and now they're saying
no. If they're tiptoeing around, because a lot of times when CEOs leave, everybody's a little nervous, like and so I'm having a really good opportunity to just be able to spread the word that it's your terms, it's your timing, it's really something that you've been able to navigate, and you're the pilot of this. So know it's not happening soon. No, it wasn't happening against your will. So it's been fun to just get back to the community and saying, no, here's Gary's announcement. So while we're excited for you, because I know you have all of these grandbabies and another one on the way, it's weird. So tell us about it.
Weird. Yeah. No, you're right. So the CEO is the only employee at Kuya Health that actually has a formal contract with the board of directors. So every other employee is what's called an at-will employee, but the CEO is actually a contracted employee. And I guess there's pros and cons to that. The con is that I could be terminated for whatever reason. The board could just choose to terminate my contract. And the average life, I'll say contractual life, of a hospital CEO these days is around 3 years. So I'm approaching 8 years as a CEO, and I'm in my 34th year as a Kuya Health employee. I did that contract I'm referring to. Generally, it's for a 3 or 4 year term. And so back on July 1st, 2022, I entered into a new 3-year contract with the board that would expire on June 30, 2025. The board asked me if I would be willing to make it longer, and I said, well, how about you give me the option to extend it for one additional year to June 30, 26. If I find that I'm still having fun and enjoying, I'm not quite ready to retire at June 30, 25, that I could exercise that option. And they said, Gary, we'd love to do that, but we want at least a year's notice before you retire to give us ample time to recruit the next CEO. So that meant on June 30, 2024, I had to inform the board when I was going to retire, because if I was not going to extend it, then I needed to let them know on June 30, 24 that I'd be leaving on June 30, 25. So I let them know on June 30, 24 that I was going to exercise the 1-year option, and they were thrilled by that. And so when June 30, 25 came around, they asked me, are you going to extend again? And I said, no, I think I'm ready. I'll be 66 years old when I retire. I am having fun right now, but I'm ready. I'm ready for myself personally, for my family, for my grandchildren and children, and just the next chapter of my life. But I think it's also good for the organization, to have new leadership, whether we have some outstanding internal candidates or looking externally. The board has formally engaged a recruiting firm called Peak Recruiters that is well established across the nation. So they are conducting the national search, and they will bring some outstanding candidates, both externally and internally, to the board for its evaluation. I will tell you that it has been an absolute honor and a privilege, and I consider myself truly blessed, not to just have been, serving as the CEO for the last 8 years, but my entire time at Kuya. I am so grateful for the opportunity, and I really feel I will always be in debt to Tom Johnson, who hired me, and then the board, who had the confidence and the belief in me that I could successfully transition from the chief financial officer to the chief executive officer. The support I've got from the community has just been overwhelming. At the time that I was being considered for the CEO, tremendous community support and writing letters, and support to me, and now announcing my retirement, just a lot of people reaching out to me and congratulating me and expressing appreciation. And so it's going to be hard. I mean, it feels like a long way away still, June 30 of 26. Although I've told the board, if they are successful in selecting the next CEO sooner than that, then I don't want to stand in the way. Mm-hmm. So I would imagine they'll start bringing candidates through probably in the fall. And if they, find the person that they want, again, inside or outside, then I would be prepared to step out, of the way, and with no regrets. But I am going to miss, I've had such good fortune. I've worked with so many amazing people. I work today with so many amazing people. I will miss them tremendously. I will miss the challenges and the complexities, and but I know what lies ahead will be rewarding too.
Yeah. So a couple of questions around this. So, a lot of work to be done at Kuya. So now that you've announced this retirement, how are you going to keep yourself motivated and engaged? Because part-timer syndrome, we see that a lot in leaders. And so what is your...
Well, if you'd been at our exec team meeting today, you would see that I am still highly engaged and still confronted with endless challenges. So it's not something you can just shrink away. So I think, number one, I feel a tremendous duty and responsibility to the organization.
Mhm.
Um, I exercised my option to stay another year because I felt I had unfinished business, frankly. Now, I was not anticipating OBA coming along, which is very disappointed because I think we were on a roll.
Mhm.
So I knew that it would take us, into fiscal 26 to get fully back on our feet financially and to really achieve the quality and safety, you know, um, expectations that we have set for ourselves. And we just came off a major engagement working with a renowned outside consulting firm that we've implemented many, many process changes in our emergency department and elsewhere to, again, elevate that experience. You just shared with us earlier this week, so how we ended the fiscal year with looking at some outstanding improvement in our patient experience from even the emergency department, seeing it on the rise as well. So um, I don't want to stop. I'm not going to be derailed by OBA,
Mhm.
but it has taken a little bit of wind out of our sails. I think where the headwinds have just gotten stronger. I think there are always headwinds, but no, I intend to stay fully engaged with my executive team, with the board, with this community. I don't want to go out with a whimper. I want to go out with a roar, so to speak.
There's
So,
an art to leaving well,
yes.
and you mentioned Tom Johnson, and that's something I think about with Tom Johnson. It's like, you leave well and you leave with good relationships and you leave with, your head held high because you finished strong. So,
Yeah.
all right. Well, thank you, Gary. And I think
All
we're ready to
right.
go.
Well, wow. Stuck the landing, huh, Daniel? All right. Well, thank you all for tuning in this month. If you're not catching us live, maybe you're catching us on a later recording. I've also already provided kind of not the transcript, but written answers to all the questions that you posed to us and Deborah posed. So we post those on.
Yes, we can. Yeah.
Okay. Yeah. So we make those available to you as well. So again, thanks for all the great questions. Thanks for hanging in with us for these last 5 years and continuing to be ambassadors for the organization. You ask tough questions, and I appreciate them. You help us become a better organization by pressing us, and so continue with your support, but also your expectations of us. So I hope you all have a great weekend. I can't believe how beautiful it is outside. I think it's going to be a nice weekend. I don't want to jinx it. I feel very bad for the people living in the Midwest right now. They're suffering from some pretty healthy heat and humidity. So let's soak it in while we can. So we'll see you next month.